well. There is still, again, attached budgetary issues, because the issue of promotions is not only for the Ministry of Health at the county level. It's the issue of County Public Service Board. It brings in the Ministry of Finance as to availability of this budget, then pre-planning. So in a nutshell, what am I saying? I'm saying it's good to promote the doctors, particularly those who are due for promotion. But this must be done in a graduated way so that then you have got the resources in the first place to be able to handle the numbers that you have. The other one is the question of study leave. I have talked about it. This one is is something that has been, big. You see, the doctors are saying, like, release all of us. You have got 60 doctors, 30 of them have applied for study leave and go to university. You, as the CEC, you have got priority to serve the population. And that is the primary responsibility. So you need to balance up. What are the issues? Then the issues, you say, I can afford to release 5 of you because I cannot afford to release 30. So these are decision makings at county level. You look at what is the best way of handling. Then finally, just to conclude that, we have seen these notices. The Council of Governors is, also having a discussion. The National Government Ministry of Health is having a discussion on those issues that were in the CBA, then what was implemented, what is pending. So that it's not just a threat. We can say we have implemented everything, and there's nothing for you to strike. On the issue of the second question, that was the issue of FIF bill. I think this we have agreed is something, the way to go. Why it has not worked in some counties is, like you correctly said, either the Treasury Department does not want to release this money. And there's no two way about it, because the Council of Governors now is saying we must do it. So the Treasury Department of the county government cannot hold the Ministry of Health at ransom. That you need to get it very clearly, bring the FIF bill, consult the governor, bring it to the cabinet, let it be discussed, let it be taken to the assembly. The next place is the county assembly, where it usually stagnates. And this, you need to go through the health committee of the assembly. The moment you pass it at the cabinet level, engage the health committee, lobby, because at the end of the day, it's not you, the CEC, who requires. It is the common man and woman, the relative of that MCA, the voter of that MCA who requires those services. On the issue of prevention, which is the last question I think that was posed to me, again, we have not looked at the economy of scale as what is the biggest thing that you can do, the smallest that you can do that can bring the biggest amount of benefit. If we are able to prevent disease at the primary level, for example, you advise safe water, you don't get cholera and typhoid. You advise on use of insecticide-treated nets, proper refuse disposal and waste disposal. These are all basic things, treating people at the primary healthcare level. Some of these cancers, the carcinogenic stuff is what we ingest. So if we invest in the primary care network, in terms of health educating, in terms of availing the basic thing, in terms of availing preventive screening for cancers, these are some of the things that were tried and tested and confirmed. Ours is only that we have been dealing with a dilapidated secondary health system that requires urgency. For example, if somebody requires dialysis, he has gone beyond the primary care level. And if you don't provide that dialysis at that point in time, then you will as well sentence him or her to death. This is where we have been struggling. We are somewhere as a county and as a country. It is time now to go back to prevention so that then we don't have so many falling into coming to the secondary health facilities. Thank you.
Thank you, Waziri. Another round of applause. Tulipigia Professor Mutaha makofi. Ebu tumpigie tena kama tumesahau. Dr. Sitinei, your time have been stolen.
I know. I'll try to
see how you can be able to summarize.
Yes, so I'm going to be very brief. First, I think Dr. Mwarogo is asking, when is it available? First, the system is already up. And I want to encourage the CCs who are here, when you have time and you're in Nairobi, just go to Kajiado, you go to Kitengela Sub-County Hospital. You'll see the system, how it works, and the fact that it is already working. What we were only waiting for is to officially launch it and then start to scale it. That answers also the question from Elgeyo  The system is able to take stock of whatever medicines you have, You can interact with the people in the pharmacy department. They'll tell you whether they are still struggling to calculate. They don't. They only print reports. And you can get report from any time for any commodity at any single time. There was a question of the owner of data. Who should be the custodian of the data? The Data Protection Act 2019 is very clear about the owner of health data. And it has specifically put it as that the owner is the data subject. The data subject is the owner of the health data. It is not owned by anybody else. The Kenya government is the custodian of that data. So anybody who collects the data should be cognizant of those two facts. And that is why the national government is trying to roll out some infrastructure to provide this data for the bigger good, for the individual good and also for the bigger good in terms of public health responses. And that is only possible in an environment where systems are comprehensive, systems are integrated, so that all the data elements are captured. I hope that is clear. As the process is being rolled out, particularly the National Optic Fiber Backbone Infrastructure, Lamu in King Fahd Hospital already has benefited, and I know there are several other hospitals which have benefited, and we have been in consultation with the previous regime to roll out the system in King Fahd. You can buy Fansoft, you can buy whichever. We really don't mind, or anybody can stop the counties from doing that. The only challenge that you'll face is that you'll still have disparate systems. Fansoft focuses on money collection in the health facility. And that is a very good incentive for facilities and also for counties. But you forget about the patient. But the system that the government has come up with is patient-centric. That's the difference with these other systems. So it focuses on the patient. And as the patient goes around seeking services in the health facility, everything else is collected. For example, if your problem is on money, you'll be able to know how much has been collected cash, how much has been paid through M-Pesa, how much was bank transfer. And that process is an ongoing process. For example, as I speak right now, the system has been connected to M-Pesa, so you can track how much has been collected by M-Pesa. We are still working with the bank, KCB, to link it to KCB so that when somebody pays or transfers money, you at your comfort, you will be able to see how much was transferred. And also more importantly, you will be able to know how much has been waived, because somebody will still pay for that what is considered as free. It is not free. Somebody is paying for it. So at the end of the day, you know how much has been waived, how much was paid cash, how much was paid through M-Pesa. You can get all those transactions by a click of a button using that system that is in place. So Lamu, we are going to come there. We only need to discuss. The question of telemedicine, yes, I will come back to this as I wind up. It's good that Nandi is already doing some telemedicine. There are some challenges that we are now facing that is not just for telemedicine, but for everything else. First, we do not have a policy which is out. But the thinking at the ministry headquarters is that this country will be clustered so that the national referral health facilities can take care of a particular constituency. And that means those counties must have a relationship with the telemedicine center, in which case it will be a level 6 facility. And there is a lot of work which needs to be worked out in that. For example, who is going to pay the costs for the clinician in both ends, at the national referral facility and also at the facility where the patient may be seen, or even the provider. So there has to be some form of agreements that have to take place between those constituencies with the level 6 facility which they are going to be linked. And we are still working out that to see how best that can be done. Huduma number has actually not been actualized because the law has not been passed. But the system that I described is already using IPRS. And the IPRS is Integrated Personnel Registry Services. That is where your ID number is, all those other things. So once the Huduma number is activated and it's passed by law, the systems will be integrated in such a manner that you'll only have one number. Presently, and this is where the unique patient identification number is coming on board, is that we are encouraging facilities to use any number that the government has given you, be it a driving license number, an ID, whatever you have, because government has given you something to uniquely identify you. But gradually, we are going to move towards biometrics. The only challenge with that is the cost of implementing biometric services. But yes, that is where we are going to end up. And finally, for these systems to succeed, whether it is FundSoft or money-related or any other system, you must have the right infrastructure. That is very, very critical. So in my presentation, I put a slide there, and I put infrastructure, that the counties should be able to provide the infrastructure that is required where it is missing. And the infrastructure here means if you don't have a local area network within the facility and your government has not given you resources from the national level, then you should be able to work with the partners for that to be done. The other thing, which is the most important of all, is the change management. Now, we have seen facilities where people are very keen to go to digitization. There are also facilities where individuals are just averse to getting to change towards digitization. And I don't know why. I think they must be having something that is making them go that route. So we will be calling upon the counties that are willing to go this extra path to work on the human resources that are available at that particular level so that they can be able to use the system. Because at the end of the day, any system is as good as the users. And if the users don't want to use the system, it will not succeed. So those are the two critical issues that must be addressed and have to be addressed even as we go ahead. And of course, finally, the benefits are vast. And I'll tell you that when you install this system, for example, those of us who are interested in money, you'll find that your collections go up almost 5 times. Maybe the question will be, where was that money going before I submit?
Thank you very much, Dr. Sitinei. Thank you very much. Please let us be upstanding as we are proceeding for lunch to actually applaud our panelists. I hope they have done justice to the questions, right? Have they done justice to the question? Are we together? If I say, are we together, you say, yes, we are together. Are we together? Sijasikia. Are we together? Is it clear? Mumeelewa? Mumesoma? Thank you very much. At this juncture, I want to appreciate our panelists. That was a very good panel. I hope the others also who are coming in the afternoon will be more interesting. In the afternoon, we decided to put for you a panel session. So it will be very, very practical. Look at the program, prepare your occasion. The PS for Health will be joining us in the afternoon. So we'll be having very, very also interesting session with her. So at this juncture, maybe before we finalize on this, I want these particular counties to just see Joanne and Samora. They are in the room. They are planning to meet you in the evening. But just see them now so that you plan how you are going to meet in the evening. West Pokot, Turkana, Samburu, Marsabit, Mandera, Garissa, Isiolo, Wajir, Tana River, Lamu, Taita Taveta. Just for 3 minutes before you go for lunch so that you plan for the evening meeting. Partners are also riding on this meeting so that they can be able to interact with the counties that they are working in. So thank you very much. Tuwapigie makofi. Let us have a photo session with you. Thank you very much. And please, let us just take around 45 minutes for lunch. Lunch is served on the other end. I know all of you must be having your voucher, lunch voucher by now. If you don't have, kindly ask the secretariat. They are seated behind. Afternoon session will be moderated by my colleague, Mebo Abor, seated here. So my session ends here. See you tomorrow. Thank you.